Well, there's really two components to that. There's basic medical labs like blood counts, blood chemistry, hemoglobin A1Cs. Those are pretty cut and dry as far as where those lab values go and what they can interpret. They aren't good or bad. Then you look at other things, hormones, whether it be thyroid, testosterone, estrogen, cortisol, parathyroid hormone, all of these hormone things, they have a much different interpretation. They are lab values, but then there's also treatment reference ranges, which are completely separate from what the lab does. We use those numbers, but then we incorporate them into what are pre-designed or well understood documented treatment reference ranges. So in other words, the lab tests 1,000 people and they get a set of labs. Now what labs do is they take out the bottom 10% and the top 10% of all those labs and just take them out. So they give you the middle set of labs, and that's where people look to see if they're in that reference range. One of the problems with it is people inherently that are getting their labs done tend to be a little bit sicker than the cohort or the group of people across the board. So what happens is you might look like your labs look amazing, but you're really comparing it to people who tend to be a little bit sicker, because healthy people, people who are doing really well, are not getting a lot of labs done. So they're not there to pull that reference range up to make it a much more even distribution.